We are moving on to the next topic. Dr. Bijoy Balakrishnan, he will be talking on the topic optimizing monochorionic twin pregnancy outcomes. Sir is the consultant, fetal medicine unit at Cymer in Ernakulam. Welcome, sir.
Good afternoon, everyone. And let me start by thanking Jai Krishnan sir and the entire team for giving me this opportunity to be here. And I've been asked to talk about optimizing outcomes in monochorionic twins. There is a short answer and a long answer to that question. And the short answer will not get over in 20 minutes. It's completely impossible. And if I give you the long answer, you'll probably all go off to sleep. So, what I've done is I've given you a collection of things that you should ask your sonologist or your fetal medicine specialist whenever you send a twin pregnancy for a scan. So, this is something all of you can do. All of you can see whether these factors are all accounted for in that scan report that you get. The first and the most obvious thing would be chorionicity and amnionicity, because twins do not exist. They exist only if they are labeled as per their chorionicity or amnionicity. And remember that the best time to assess that would be as early as in the pregnancy. Best time would be around 8 to 9 weeks. Now, if you are trying to differentiate between monochorionic, monoamniotic, and monochorionic diamniotic pregnancies, remember earlier is not better. It would always be better to wait till around 11 to 12 weeks, because that is when you would be able to see the membrane very clearly, and sometimes you might have to do a transvaginal scan to actually see the membrane. So if someone tells you that they are looking at a monoamniotic pregnancy at 8 weeks or 9 weeks, wait, get them reassessed again at 11 to 12 weeks, and be perfectly sure whether you're dealing with a monoamniotic pregnancy or not. And the sure sign for a monoamniotic pregnancy would be cord entanglement, and if you see that, you can be absolutely sure you're dealing with a monoamniotic pregnancy. With that, we come into the first trimester, and what are the specific things that you should ask for? First one is obviously screening for aneuploidy. Now, when you screen for aneuploidy, this is probably the only condition where it's good to be a monochorionic pregnancy, because the risk of having a baby with Down syndrome for a monochorionic pregnancy is far lesser than a dichorionic pregnancy. To explain that, let me give you this example. If you have a singleton mother with a risk of around 1 in 300, if she is having a monochorionic pregnancy, a monochorionic twin, her risk remains the same, around 1 in 300. But if she is a dichorionic pregnancy, then the risk jumps to 1 in 150. Means either one of the baby having Down syndrome almost doubles, but the chance that both of them will have Down syndrome is extremely, extremely unlikely. And the best example that I can give you is try to go out and get hit by lightning. The number of times that you go out into a thunderstorm, the chances of getting hit by lightning increases. And that's why in dichorionic pregnancies, you have two pregnancies, two separate pregnancies. So you're going out into a thunderstorm at two different periods of time. But to get hit by lightning both the times is extremely rare. So the chances that both the babies can have Down syndrome is extremely unlikely. But which is the test that you would use when you're trying to screen for aneuploidies in twin pregnancies? Now, I know most of you would say that it's the combined test. Now, the problem with the combined test in a twin setting is that you have a very high false positive rate of around 9%. When I say false positive rate, it means that you're going to label a lot of normal pregnancies as possible Down syndrome. And to prove that they are normal, you will have to do what? You will have to do an unnecessary amniocentesis. And so when the false positive rate is 9%, the number of twin babies that you would have to do amniocentesis for is going to be extremely high, and there is a good chance that you will lose a lot of normal babies. And therefore, the best option would be to do NIPT in twins. Although there is an argument that it would be slightly inferior in dichorionic pregnancies, most of the studies have shown that you have a 98% detection rate for trisomy 21 when you do an NIPT. So as far as trisomy 21 is concerned, the best test would be NIPT and not the combined test. Then you have to screen for growth. And when you're screening for growth in the first trimester, you should understand that the cause for growth restriction in dichorionic pregnancies is as the same as singletons. It's a bad placenta. Whereas in monochorionic pregnancies, it is going to be unequal placental sharing. And in the first trimester, your predictor is going to be CRL discordance. So whenever you send out a scan in the first trimester, they should mention CRL discordance, if any. And when you find CRL discordance, you should understand that the first thing you think of is not FGR, but anomalies. And if anomalies aren't present, then there is a good chance that these pregnancies could land up in selective FGR of either one of the fetuses. And to illustrate that example, let me show you this case where you have two babies. One baby is obviously small, looks okay on your cursory glance, but when you look closer, you can clearly see that baby has got what is called as an encephalocele. And as Vivek already mentioned, if you have CRL discordance in a monochorionic pregnancy, it's important to rule out the trap fetus. And you rule that out by switching on color Doppler and looking at the direction of flow. And we all know that in monochorionic pregnancies, the problem is with unequal sharing. So what is the clue that tells us that there could be unequal sharing of the placenta? And that would be to look at the cord insertions. So in the first trimester, in a monochorionic pregnancy, along with CRL discordance, you should ask for the insertion of the cords. Because if you find that one of these cords are marginally inserted or inserted into the membranes, that is, it's a filamentous cord insertion, then the chance of unequal sharing is higher and the chance of SFGR is also higher. So in the first trimester, along with CRL discordance, you can also ask for cord insertions. The next complication that you want to be wary of is TTTS. So in TTTS, if you want to predict TTTS in the first trimester, there are a number of markers that you can look at, like NT, CRL, ductus venosus. You can also look at serum markers like beta HCG and PAPE, which would be extremely high in those fetuses that could develop TTTS. But when you look at all these markers, as was shown in this paper, the only marker that can act as a single marker to predict TTTS would be flow within the ductus venosus. So if you find a DV reversal in a monochorionic pregnancy, in a structurally normal fetus with normal NT, the possibility of TTTS should be kept in mind. But you should also understand that the predictive accuracy of all these markers combined is extremely low. From there, we move into the second trimester. So what should we ask for in the second trimester? Obviously, the first thing you're going to ask for is anomalies, so I'm not going to go there. The risk of anomalies is definitely higher in twin pregnancies, so you need to do a detailed targeted scan. But apart from that, you need to ask for growth, Doppler, and Leica abnormalities, if any, in a twin pregnancy. And in growth, it is not enough to just ask for the estimated fetal weight. You have to ask for discordance, because you could find that two babies are growing well above the 10th centile, but the only evidence of a possible FGR would be discordance. That discordance could be just in the abdominal circumference or could be in the estimated fetal weight. So the report is not complete unless estimated fetal weight discordance or an AC discordance has been mentioned in the report. And if you find in a monochorionic setting that one baby is small or there is discordance, then you have to classify it into types. Now, types are different from stages. When you have a monochorionic pregnancy and one baby is smaller than the other and the diagnosis comes back as selective FGR, you should ask for the type of FGR. Now, why is type important? As I told you right at the beginning, in monochorionic pregnancies, smallness is because of unequal sharing. And by knowing the type, you can know the degree of placental share. By knowing whether there is normal flow within the umbilical artery of the smaller baby, you will be able to say whether the share of placenta is good or bad. But how does that make sense? Because we have already heard and learned in various platforms that if the umbilical artery is abnormal, it means that the placenta is bad. But if the placenta is bad, how is it that one baby is growing well and the other baby is not growing so well? So the placenta is good. In spite of that, you're getting an absent end diastolic flow within the umbilical artery of the smaller baby. To explain that, let me give you this example of a child trying to blow air into a balloon. If the balloon is big, large, and elastic, it would be easy to blow air into it. But if that balloon was thick, hard, and tough, what would be the condition of this child? It would find it difficult to blow air into that balloon. Now imagine blood volume that is being pushed into a normal placenta. The child would find it easy to push it into that placenta. But if the placenta becomes smaller and smaller, it has to try to push all that blood into that small placenta, and it is going to create what? Stress on the baby's heart. And the baby is unable to push blood into that small placenta, and therefore, which part of the cardiac cycle is going to be affected? The diastolic part of the cardiac cycle, and therefore the flow in the diastolic part of the cardiac cycle disappears, and you get absent end diastolic flow in the umbilical artery in a good placenta, because the baby is unable to push blood into that small placenta. So when you classify it into types, type 1 has got diastolic flow presence within the umbilical artery, which means its placental share is less but not very bad. When the diastolic flow disappears from the umbilical artery, you know that the share is lesser, and therefore in type 2 the share of placenta is lesser than in type 1. And in type 3 you have intermittent absent end diastolic flow or intermittent reversal, which is something new. It is not seen in any other type of pregnancy except in monochorionic pregnancies, but that type has got the least share of placenta. So why does that happen? To understand that, you should understand a little bit about the vascular anatomy of the placenta. In the placenta, there are large anastomoses called as AA anastomosis, which take blood in either direction. So fetus A has got an artery that supplies the placenta, and fetus B has got an artery that supplies the placenta. Now, if the volumes are good on either side, they would meet somewhere in the center of the placenta, which is called as the collision point. But if the share of placenta on one side is very less, then blood from the side that has the larger share will push the blood all the way into the side of the smaller twin, and any pressure fluctuations that are happening in that anastomosis will be immediately evident within the umbilical artery of the smaller twin. So in type 3, when you get intermittent absent or intermittent reversal, as is shown in this picture, the placental share is the least. So type 1 has got moderate share of placenta, type 2 has got low share of placenta, and type 3 has got the least share of placenta. So whenever you get SFGR in a monochorionic pregnancy, it is essential that they tell you which type of FGR you're looking at. Then we go into Leica, the most easiest thing that you can measure. And this Leica discordance happens because of another anastomosis that is running within the placenta. And this is an arteriovenous anastomosis. This can take blood only in one direction, unlike an arterial anastomosis. And in a normal monochorionic pregnancy, the number of AV anastomosis running from one side to the other and vice versa would be almost equal, and therefore there will not be any Leica discordance. But when there is an imbalance, you will get Leica discordance, which leads to oligohydramnios in one sac and poly in the other sac, giving you the classical diagnosis of twin-twin transfusion syndrome. Now, this happens because of an imbalance in the arteriovenous anastomosis. Now, it's not enough to just say that there is TTTS. You have to classify it into stages, not types. And here, stages will tell you about the severity of the disease, and you classify it into stage 1, where there is only Leica discordance, stage 2, where the bladder of one baby disappears, stage 3, where you have Doppler abnormalities, stage 4, where you have hydrops in one, and stage 5, when one fetus dies. So it's important to classify it into stages. And it's not just enough to stop there, you have to proceed further and look at the Doppler findings as well. And in the Doppler findings, it is important to look at your traditional Dopplers, like the umbilical MCA and DV, but you should also ask your sonologist to look at the cardiac function of the baby that is receiving more blood, or the baby that is having polyhydramnios, because the report is incomplete unless you know the cardiac function of the recipient. And we look at a certain number of things that we usually assess in the baby that receives more blood, like the size of the heart, like the inflow into the ventricular chambers, and the blood flow across the great arteries, and of course the DV. It's not difficult, it's extremely easy to look at it if you know what you're looking for. On the left hand side, you can see a heart that is big, and you can see regurgitation across the mitral and the tricuspid valve, telling us that there is severe diastolic dysfunction. And on the right hand side, you can see that there is reversal across the pulmonary artery, telling us we are looking at functional pulmonary atresia. So this patient came to us referred as TTTS stage 1, but the condition of this heart told us that in spite of the fact that this baby is in TTTS stage 1, there is a good chance that this baby may die in utero, which would prompt us to do a laser and try to take out the anastomosis that connects one baby to the other. So basically, the idea here is to correct the imbalance by taking out the arteriovenous anastomosis that runs from one baby to the other. Now, so we need to look at cardiac function. We need to look at all the Dopplers that we mentioned. But there is one another Doppler finding that you need to look at that we may not look at in our routine scans, and that is the middle cerebral artery peak systolic velocity. It is not normally done unless the fetus has a risk of developing anemia, but in monochorionic pregnancies, this has to be routinely done from 20 weeks onwards because of a possibility of an anomaly called as twin anemia polycythemia sequence, where one fetus has got polycythemia and the other one has got anemia. Here again, you have to know the discordance or the difference in the MCA PSV and not just the mom values. You need to know if that difference is greater than 0.5 moms, and once that difference goes beyond 0.5 moms in spite of the MCA values being normal, there is a good chance that this fetus could have this particular complication called as twin anemia polycythemia sequence. Now, if they mention that there is a discordance in the MCA PSV, then you should ask them to look for other signs, like the condition of the liver and the placenta. Now, the liver and the placenta of the polycythemic baby will be different, will show signs of hypoechogenicity with increased echogenicity within the liver, which is called the starry sky pattern, or the placentas will show difference in echogenicity as well. A combination that tells us that we are looking at a very unique complication, a rare complication that is called as twin anemia polycythemia sequence, and a complication that can be treated by actually correcting the polycythemia and the anemia as well. So it's a condition where we correct the anemia of the anemic fetus by giving blood transfusion, and we correct the polycythemia by taking out blood and putting in normal saline. So the idea here is to prevent this anemia from progressing further and damaging the baby that has got anemia, and the polycythemia from further becoming bad and causing a problem that can affect this fetus also. Now, coming to the third group of pregnancies in monochorionic twins, which is the monochorionic monoamniotic pregnancy. Now, I know all of you are worried about cord entanglement, and whenever you get a pregnancy that comes in with a report saying that there is a monoamniotic pregnancy, the knee-jerk reaction is to offer termination. I've had a lot of people who come in saying that this is a monoamniotic pregnancy, the risk of double intrauterine fetal demise is extremely high, and therefore we should offer termination. Now, I want you to, if possible, read up this paper, which looked at the association between cord entanglement and fetal demise. The fact is, there is no association. And the reason why there is no association is because cord entanglement is always present in monoamniotic pregnancies. And the reason why these babies die is not just because of cord entanglement, but because of a sudden exsanguination that takes place across the large AA anastomosis which runs across the placenta. So one of the methods by which you can predict it is by looking at the umbilical artery diastolic flow. So if you have a monochorionic pregnancy with a monoamniotic pregnancy, the protocol that we follow is that we admit this patient from the period of viability and we put them under close surveillance, and we look at a specific finding within the umbilical artery, which is diastolic notching within the umbilical artery, which tells us of the possibility of sudden intrauterine fetal demise. Now, in spite of doing all that, you should keep in mind that there is no way to predict whether this baby is going to live beyond 32 weeks, and therefore we all go in for elective preterm delivery at 32 weeks. Now, why 32 weeks? Because the chance of intrauterine demise for a monoamniotic pregnancy after 32 weeks is 1 in 25. But the chance of preterm death due to delivery at 32 weeks is around 1 in 80,000. And therefore, the risk is strongly in favor of early delivery, and therefore we deliver at around 32 weeks. To sum up, I hope I was able to convey to you all the things that you need to ask. But if you can't ask, there is a schizophrenic, paranoid person in your district who's called as a fetal medicine specialist who will definitely help you. Thank you so much for listening.
Thank you, doctor.